I think some of the important things to take home from this are that we like to correct as much of the astigmatism in the lenticular plane as we can. I think it's much more effective and predictable. So for instance, in this eye, which has nearly 2 diopters of corneal cylinder at the 46-degree axis, if we look at 100% correction with the intraocular lens, we have only a residual of 0.03 diopters in the 46-degree axis. If we corrected it all with AKs, we would see that first of all it would require 38-degree paired AK incisions, and not only that, those incisions would cross our primary incision, necessitating moving that primary incision sometimes to an awkward axis to operate. So we like to keep the bar over to 100% of lenticular correction for astigmatism if at all possible. If there is some mixture, let's say there's a quarter of a diopter that's going to be left over after 100% IOL correction, we could then go ahead and add a small AK in the same axis. So that is one way we look at that. A second point that I like to make is that not only do we like to correct as much astigmatism as we can in the lenticular plane, we also like to correct both eyes with the same technique. In this particular patient, however, there is not enough corneal astigmatism in the right eye to justify or warrant a toric lens, and in fact a toric lens would flip the axis. So in this particular case we will be doing AKs in the right eye and a T5 lens in the left eye. Okay, well we've got a cataract surgery here where we're going to be implanting a T5 lens, axis 46 degrees, in a relatively mild cataract here. So I want you just to keep looking straight ahead here at the center of those lights. Very good. Try not to move a muscle. Excellent. Suction. Okay. Yep, there we go. A little bit of air. And we're also going to be demonstrating the VERION system. And I think the VERION, the first thing you notice here is there's no marks at the limbus, and we no longer have to do that, as the VERION will auto-rotate this and auto-focus and auto-center the capsulotomy, as well as auto-place the incision based on a preoperative high-definition photograph of the eye that we use to register the patient, both in terms of the limbal vessels as well as iris structures as well. The VERION has made our office and OR much more efficient, and made the procedures proceed much more smoothly. See a nice capsulotomy here, well centered, 4.9 millimeters. We use the grid pattern fragmentation along with 2 cross incisions. As you can see here, our primary incision then is made. In a matter of about 20 or 25 seconds, the laser will do the entire procedure. And we're going to be demonstrating the use of the VERION and how beneficial it has been for us, not only with placement of toric lenses in terms of the axis, but also centration of restore lens. Here we see the overlay of the VERION, and we notice there are no marks on the limbus preoperatively, which has been a real advantage for us. We've used a reference photo that was taken at the reference unit prior to surgery, identifying these blood vessels at the limbus as well as certain iris structures, and we use that to register the cyclorotation of the eye during the procedure. We have been very impressed with the VERION in terms of not only the measurements and the ability to account for cyclorotation, but also the surgical planner has been a real beneficial aspect of that as well. The first thing we're going to do here is just open the incision, which is outward a 2.3 millimeter incision, inwardly a 2.5. So it's very simply opened with a Sinskey hook. We use intracameral xylocaine. See, the pupil is very well dilated here. I want to point out the capsulorhexis that is done and the overlay with the VERION unit, and this can be centered not only on the visual axis as we've done here, but also on the preoperative pupil, as you can see here, as well as the limbus. And we can see that the limbus is usually centered a little bit further temporal. Now look right at the light here for us, nowhere else. So we use the visual axis, but for those that are doing manual capsulotomies, it's a very good way to center and get an appropriate diameter capsulotomy. We inject viscoelastic into the anterior chamber and see that we have a free-floating capsule, which we do virtually every time now, the new soft fit patient interface. And I prefer to hydrodissect subincisionally first. We are going to use a one-hand technique here with a pre-chopper to remove this cataract. So with the pre-chopper, we simply go through the incision and separate the nucleus. We will then spin. We use a series of 4 chops with the femto. I use foot position 2 with a little bit more aggressive parameters to remove bubbles and debris and from the anterior chamber, including the anterior capsule. And then go back into foot position 1, which is sculpting. Here the nucleus was really much more dense than I realized, so we didn't get good chops. I'll show you the alternate way that we do this. I will then debulk the central nucleus, re-inject viscoelastic, and then go in with a pre-chopper and demonstrate the 8 sections that are made with 4 chops on the femto. This is a very good technique for the more dense cataracts. And makes removal of those cataracts much easier. As we simply then go in under fragment removal and pull out 8 small pieces of peripheral nucleus. In very short order, the nucleus is removed, the anterior chamber is clear. This is the balance tip with sleeve, and you can see the dual bend, which makes the torsional component of phaco emulsification almost twice as effective. And we've had to actually reduce our maximum power to 60% because it is so efficient and timely. We've been able to reduce the amount of phaco energy used not only with the Centurion but with the Centurion plus femto. And a lot of that has to do with the ability to be flexible with our parameters because of the active fluidics. We tend to set our intraocular pressure at a target of 75, which we find very adequate throughout the procedure. I would encourage anyone who is getting a new machine to spend the time it takes to maximize your settings early on and really take advantage of the technology that we have available to us today. So now we will inject the Toric intraocular lens. Again, this is a T5, and we will be using the AutoCert injector. Which you can see here, we use the same cartridge, the D cartridge, and the second hand is now free to stabilize the globe or direct the lens inside the eye. So we will use the VERION now to give us the overlay, and we see that our axis is at 46, so we will rotate this lens with the viscoelastic still in the eye to about 10 degrees short of the desired axis. Now you can maybe hear that this patient is sound asleep, totally relaxed with his Versed, and yet we are still able to identify the axis without marks on the conjunctiva because of the VERION, even though the patient is not fixating on the light. That's also an advantage with the Luxor microscope in that the red reflex stays very, very obvious even when the eye is not directed at the light itself. So we are now going to go into a final placement of the lens, and you can see we are very close. Maybe rotate another 2 to 3 degrees, and now we are just right on it here, and it looks perfect.